Thyroid disease management. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. So as an introduction, thyroid disease can greatly impact maternal and fetal health during pregnancy and postpartum care. The thyroid regulates the metabolism, energy, growth, and if there's a dysfunction in place, whether it's hypothyroidism, where the thyroid is not functioning at the normal, it's a low level, or hyperthyroidism, where it's functioning at a higher rate than it's normally supposed to, requires careful management by the midwives and closely working with the healthcare system. Depending on if you're a certified nurse midwife, certified professional midwife, direct entry midwife, we each have skills and expertise that are different in understanding thyroid disease and management. Hypothyroidism is the common thyroid disorder in pregnancy. It's where the thyroid underproduces the hormones. It can cause fatigue, weight gain, cold intolerance, and depression. And if it's not treated, it can have complications like preeclampsia, anemia, miscarriage, developmental issues in the newborn. The way I describe it is your thyroid is like an engine to the car. And so if the motor is running low, the gas isn't going around, it's sluggish, it's just your metabolism slows down, everything slows. And then when you're hyperthyroidism, that engine is just revving and it's going on hyperdrive, and it's going to get tired, and it's producing, and you're just like jittery and you're anxious and your metabolism is on overdrive. Those people tend to be losing weight, and they have just challenges with relaxing. They're more anxious. So think of your thyroid as that engine, that metabolism driver of your body. Midwives monitor for symptoms and recommend thyroid function tests. So there's the thyroid stimulating hormone, there's T3, there's T4, there's thyroid panels. It just depends on how complex. If you're trying to get a baseline, this is the first time she's been assessed for it. She's got extreme hypo or hyperthyroidism. She's had some surgery. She's had some medication treatment. Depending on the situation, determines which type of thyroid panel to do. Typically, the treatment involves levothyroxine with careful dosage adjustments and regular monitoring of the mom and baby. So usually during pregnancy, it's every 2 to 3 months, and then you'll continue to monitor her thyroid level for up to a year postpartum, because of all the hormonal changes really impacts that baseline of thyroid meds that she's on now. Her body may regulate and get itself back to normal, and so you want to make sure that she's on the accurate dosage based on what her body needs at that time. Hyperthyroidism, often called Graves' disease, is a result of excessive thyroid hormone production. So these people are more jittery, weight loss, rapid heart rate, heat intolerance, anxious, tremors. If not treated, it can lead to preterm labor, preeclampsia, low birth weight, and potentially heart failure. Midwives can help identify the symptoms and can refer them to an endocrinologist if need be. Hyperthyroidism is so much harder to manage versus hypothyroidism. Either way, it's a good idea based on your skills and specialty to involve an endocrinologist and obstetrician. But these ladies, they need anti-thyroid meds like PTU and methomazole, careful monitoring to prevent overtreatment. Sometimes they have to have surgery. It's not as common to have hyperthyroidism as hypo, but sometimes it's very serious. And there may be an underlying condition, that there is a node or a cancer with the thyroid that family history, we just have to dig into. Rare situations, you have to do radioiodine therapy or surgery, but definitely hyperthyroidism is a little more complicated to manage and definitely should be managed at any specialty of a midwife with an endocrinologist or an obstetrician. Subclinical thyroid disorders. So these are just mild imbalances with minimum or no symptoms. Like I've had ladies where they have a strong family history, or they had thyroid issues in the past and they've been normal for years. They don't feel any symptoms, but you get a baseline thyroid panel and it's off. And so there are discussions of like annuals, doing vitamin D, doing a thyroid panel, doing everything with lab work, not just hypertension vitals and diabetes A1C screening, but actually adding a lot of these things, because a lot of people have hypothyroidism and don't know it. They're just gaining weight, they're tired, they think it's just life and demands, but it's really their thyroid. So I stress to people, even though the symptoms are less severe, they still can increase the risk of complications like preterm birth and developmental disorders with a baby when you have subclinical thyroid disorder, just as much as hypo and hyperthyroidism. So it's definitely something to consider, adding a thyroid panel, or at least just getting a thyroid stimulating hormone, depending on the cost, if insurance will cover it, and having a discussion with your client. Thyroid disease postpartum, some people will have normal levels pregnancy, but just all the hormonal shifts and the stress level postpartum can cause thyroid issues. And so it's postpartum thyroiditis, a temporary phase of hyperthyroidism followed by hypothyroidism. Symptoms include fatigue, mood changes, weight retention, and so it's hard postpartum. Some of these things, is this normal postpartum hormonal shifts, or does she have an underlying thyroid condition? So sometimes getting a simple lab just to rule out that it's just normal postpartum issues versus a serious thing is not a bad idea. So you want to just refer to tests, you want to watch for symptoms, you want to check multiple conditions that could also be causing this, not just thyroid disease. So the role of a midwife during thyroid disease management, we are essential. We are the first line gateway to our patients to the medical system many times. So we can get the initial labs, we can coordinate them with the endocrinologist, we can collaborate on long-term plans, especially certified nurse midwives are primary care providers for midwives or for our clients, our patients. So even after they have a baby, you could continue to manage, or the family practice physician, that long-term thyroid. So screenings and diagnosis, you want to get a thyroid panel. Sometimes you just get the thyroid stimulating hormone. Sometimes you'll get a TSH, T3, T4 just to get more definitive advice depending on cost and how severe the symptoms are. Education, counseling, the things, there's supplements you can do, there's stress, there's certain things that'll help improve your thyroid health. And then having a good discussion with them about risk and benefits of what these labs mean. And if you leave it untreated, what is the long-term potential complications with your thyroid always making up, and you have a low thyroid level, and so your body is compensating in some shape or form. And do you need some medicine? Do you need some treatment? Do you need some underlying lifestyle changes? And then we do some serial labs to keep an eye on it. Collaborating with a specialist, obstetricians, endocrinologists, postpartum care, keeping an eye on it. I think too many times the thyroid panel is only done at 6 weeks postpartum, and it really should be monitored every 3 months for the next year, because there's so many changes, and that dose she's on at 6 weeks postpartum may not be the same dose of medicine she needs to be on at 6, 9, 12 months postpartum. So as an overall conclusion, thyroid disease impacts pregnancy and the long-term health, particularly a mom and baby with development, with risk of preterm labor, with preeclampsia. By recognizing these as symptoms and getting some simple testing done and starting the treatment plans and the lifestyle changes, we can really improve the outcomes for our moms and babies.